Hi and good day, everyone. We're back here. This is Dr. J. Tan, and we're back here now in our discussion video. And this time we'll be talking about the pharmacologic management of psychosis. From the previous lecture content material we have on video, we were talking about anxiety, and then we went into the mood disorder, pharmacologic management. That was then we were talking about your unipolar under mood disorder, unipolar depression, and then we went into bipolar pharmacologic management. So this time we'll be talking about pharmacologic management of psychosis, generally referring to psychosis as a general term, but at the same time we'll be using schizophrenia here as an example. So our objectives here in this discussion is that at the end of this lecture presentation, you'll be able to analyze and be very familiar with the four relevant neural pathway. And when I talk about neural pathway, here I'm talking also about the dopamine pathways. Okay, my goal here is to let you be very familiarized of these four neural pathway and how it actually impact and affect schizophrenia, if not psychotic symptoms, wherein we could utilize your pharmacologic management, understanding the neural pathway, what are our target pathway, and also what are those two in that group of pathways. Actually there are four that can also affect the side effect in the terms of pharmacologic management. So we will be discussing heavily on that, and I want you to pay particular attention on those neural pathways that we will be talking later on. I'll try to simplify it. I try to make it more sense in how this again pathway can impact your decision in utilizing what type of medication, considering its effect, its therapeutic effect to the neural pathway as we balance out some neurotransmitter, especially dopamine, and how it does it impact also potential side effects. Then you could make your clinical judgment, your clinical decision making as to weighing the risk and the benefit, and what is its intended use, and what are we trying to prevent as an adverse reaction. And it all makes sense in this neural pathway. So we'll be talking about that. We will also be talking about the mechanisms of action in the relationship to clinical and adverse effect. And that's how somehow related again to the understanding of the neural pathway as we try to manage psychosis using pharmacologic agents in this perspective, and then weighing things out as to therapeutic versus adverse effects, or the presence of or the potential of. And then furthermore, we will be discussing about first and second generation antipsychotic. I will put them one after the other so that you could also make a decision as to which one is best for your patient. So we will compare and contrast the first and second generation antipsychotic, or commonly called also as atypical antipsychotic. And then lastly, in our management using pharmacologic agent, is we would like also to gain understanding the skill how to evaluate the importance of safety consideration with a drug presented or with a drug that we'll be using. So those are our objective, and hopefully we'll be able to achieve this going through the material we have. So let's talk about the physiology of the psychiatric disease. So in this discussion, I would like you to be very familiar into what type or which part of the brain. So it's more on anatomy and focusing on physiology that is impacted as a result, maybe what's behind behavior, signs, and symptoms of a psychotic individual, or in fact, in that case, in the case of schizophrenia, as an example of your psychosis, And also considering this um, pathway or this dopamine pathway in how we match our management utilizing pharmacologic agent. So if you remember in our biological review and discussion, and if not, I would like you to read a little bit more about these four dopamine pathways. These are your mesolimbic dopamine pathway, your mesocortical dopamine pathway, your nigrostriatal or stratal dopamine pathway, as well as your tuberoinfundibular dopamine pathway. So there are four. I included a diagram here, which I will also repeat in the next slide, about the brain, and it's color coded. So I want you to, I will enlarge this in the next slide, but I want you to pay particular attention in the color code here. So if you look at the blue, a little blue here, where it's this arrow here is the mesolimbic pathway. I will talk more about that later on. I just want you to be more familiar with that. And then the red one that runs through the cortex of the brain is actually your mesocortical pathway. All of them actually here, this colored, has some reaction to dopamine as a neurotransmitter. That's the result why they're called dopamine pathways. So you have your mesolimbic and your mesocortical. And then you have your nigrostriatal pathway, which is in light blue. This is the area here. And your green one, the smaller one here, that has somehow to do with the pituitary gland, they have your green, is your tuberoinfundibular pathway. So these are all pathways I will simplify later on in the next few slides that actually utilizes or is impacted with dopamine and its function. Okay, so I want you to be familiar with the color code for now so that it will be more sensible for you. Okay, so here's a bigger representation of that. So let's talk about first your mesolimbic. The mesolimbic pathway, which represent here where my cursor is, and the blue, is actually responsible for emotion. I'm trying to simplify it. This is the pathway that's responsible for emotion. So much also, therefore, is responsible for feelings, pleasure, reward, and this is also responsible for pleasure and reward circuit. This is also the pathway that is also impacted with addiction or addictive personality or behavior. See, not only substances, but addictions, any type of addiction, as well as perception. So that's the main function of your mesolimbic pathway here. The mesolimbic dopaminergic pathway also, when in regards to psychosis, so normally you know that it's responsible for your emotion, feeling, pleasure, circuit, certain behaviors such as addiction and perception, and the presence of dopamine actually allows you to feel those emotion, feelings, pleasure, presence of dopamine in the neurons in this pathway allows you to feel that. But in the context of psychosis, it relates to positive symptoms of schizophrenia or psychosis, especially in acute psychotic. So therefore, in this pathway, if you have too much, okay, if you have too much of the dopamine, where normally you feel that certain emotion appropriate for the time, situation, feelings, pleasure, depending on the situation, you feel that with a normal dopamine. In this pathway, what happens is if there's too much dopamine produced, we know that it stimulates. So then that is where you could see hallucination, because it's responsible for perception. So then an overstimulation of dopamine in this circuit or in this pathway allows you to have the acute psychotic symptoms, the hallucination, the delusion, the paranoia, sometimes certain emotion being angry, So those are what would happen. And this is very significant because this is the pathway later on we will have to look at, that if too much dopamine is stimulating the receptor, it creates the psychotic symptoms, which is your acute psychotic symptoms, or called your positive symptoms of schizophrenia. What do we mean, by the way, when we say positive symptoms? What is not there has been added. So the patient starts seeing things. The patient starts believing things of delusion in nature. So what's supposed to be not there was over expanded with a stimulation of dopamine in this pathway. So that is where we try to modulate by decreasing dopamine, or the stimulation of the receptor with the dopamine to control the symptoms. So, but this is where it's at. And then when we come to mesocortical, it's in red. It runs through all your cortex. This pathway here where my cursor is running, that is where your mesocortical. We would like to think in this pathway that this is responsible for the cognition. Okay, so this is where it's responsible for cognition, thinking, memory, attention, learning, and very important also are your executive function. What do I mean by executive function? Your decision making, those things that allows you to execute what your thoughts are, what your plans are. So that's why it's called your executive function. So that's responsible for your decision making, your judgment, are your executive function. And then also very important in this pathway is also your affect. Mood, we talked about mood before, is your feelings inside, but no one would know about your mood. But the outward manifestation of how you feel inside is your affect. You're happy, outwardly you smile. You're very interested. You show interest. That's your affect. It's the outward manifestation of your mood. So it is in this mesocortical pathway. But in normal person, with the presence of your dopamine, you'll be able to function here where there is enough memory, you put attention, you learn, you do your executive decision making, your thinking and cognition, your learning abilities is enhanced, in fact, is related to your day-to-day activity. Well, the problem here, I would say, that in psychosis, although there might be overstimulating with dopamine that creates hallucination and delusion in your mesolimbic pathway, in here in psychosis mostly there is deficiency. So that's why we call it imbalance. Okay, that's why there's imbalance, because what's true to one section of the brain might not be true to the other section of the brain. So the whole typical feature of psychosis in schizophrenia is that there's overstimulation of dopamine in your mesolimbic pathway, but there seems to be a lesser dopamine in the mesocortical pathway. That becomes the pathophysiology behind the symptoms, because now your mesocortical pathway is responsible to what we call as the negative symptoms of schizophrenia. So what do we mean by negative symptoms of schizophrenia? What's supposed to be there has been diminished or taken away. So in schizophrenia, or in many of the psychotic features, is that there is overstimulation of dopamine in the mesolimbic, but there is a lack of dopamine in your mesocortical. So the overstimulation of dopamine in the mesolimbic pathway, the blue one, creates the positive. Remember what I said about positive? What's supposed to be not there, it was added on. So then the person here having hallucination, delusion, feelings of paranoia, it was placed on there. Supposed to be, you don't have delusion, and then you start to believe on things. You start to be paranoid on things. That's in the mesolimbic. But talking about the mesocortical, is responsible for the negative symptoms of schizophrenia. Again, what we said, what's supposed to be there was taken away. So if the mesocortical pathway is responsible for cognition, on thinking and memory, the patient who's schizophrenic with lack of dopamine in this pathway will now will have hard time learning. They have hard time knowing, understanding things because their cognition has been blunted or decreased. It's a negative symptoms. Their memory has been affected. Okay, they hard to remember things. They don't have attention when supposed to be they will be able to maintain attention. Again, as I've said, learning is affected. They're very poor in learning. Um, there is executive function deficit. So instead of they're able to make a decision, to make a judgment, those are diminished or taken away, such as the negative symptoms. That's why it's called negative symptoms. I know I'm trying to oversimplify it. Probably to some people who's a physiologist would say there's more to it, but that's the biggest nutshell. Okay, so now you have an understanding now of a symptom of your schizophrenia, why they are having hallucination at the same time their executive function, their cognition, and their ability to understand and learn are diminished and taken away as a negative symptoms of schizophrenia. It is because of the lack and or an increase in certain pathway. In cases again of mesolimbic, it's overstimulated with dopamine. In mesocortical pathway, there is deficiency of dopamine leading to the negative symptom of schizophrenia. But this too is very responsible to the symptoms that you will see among schizophrenics. Okay, so now you could understand perhaps why there is positive and negative symptoms. Positive symptoms relates to mesolimbic pathway overstimulated with dopamine. And then mesocortical is that there's a deficiency on dopamine. So that's why we need to balance it out. And we will talk more about that as it relates to medication. Then you have two other pathways here. You have your nigrostriatal pathway. Your nigrostriatal pathway is indicated by the blue circuit here. So somehow in the mid of the brain, since in here, and they are responsible and related to movements. They are responsible to relate to movement and sensory. So it's mostly motor and sensory is the responsibility of your nigrostriatal. How does it important? Well, it is important, especially later on when we try to manage it with medication. There's not so much, okay? It's not so much more about their symptoms, although there might be somehow in types of schizophrenia who are catatonic, because it's affected with movement, but it's not the main, concern here. The main concern here is that your nigrostriatal pathway, as well as your tuberoinfundibular, is affected when we manage and control and balance out dopamine, because they are sensitive with dopamine also, but they are sensitive in a sense that they are responsible now that the imbalance of dopamine will be affected by your management. They are the pathway, both your nigrostriatal pathway and your tuberoinfundibular pathway will create the side effects and the noticeable side effects. Why? If we talk about the nigrostriatal pathway, I said it's responsible for your movement. Think about it. Then we try to use a medication. Then let's talk medication later on. But when we use a medication that decreases the dopamine stimulation in the mesolimbic, so we control, we decrease, we prevent the receptor in responding to the presence of dopamine. Well, what happened is in the nigrostriatal pathway, you need also normal amount of dopamine to maintain your voluntary movement. Okay, to maintain your voluntary movement. But when you decrease the dopamine generally in the brain, you decrease also the dopamine in the nigrostriatal pathway. Well, dopamine is needed to limit the extrapyramidal function of, you remember your extrapyramidal is responsible, the extrapyramidal system in your brain is responsible for your involuntary movement, but your pyramidal system of the brain is responsible for your voluntary movement? Well, your dopamine controls and inhibits the extrapyramidal function. That's why you try to control, so you control your extrapyramidal movement. Well, remember, in a case of Parkinson's, what's the problem? You remember, in Parkinson's, there is decrease in dopamine. That's the reason why there is the decrease in control of your involuntary movement or your extrapyramidal function. Then there's shuffling, there is tremors, there is incoordination. That's one problem, because then the presence of dopamine in this system, it controls the extrapyramidal, so it controls your involuntary, so you could maximize and optimize your voluntary action. When you try to decrease overstimulation of the positive symptoms of dopamine in the mesolimbic pathway, you also decrease the dopamine that controls and inhibits the involuntary movement. Then what happened? Then there will be more involuntary movement that is noticeable. So that's the reason why when we use certain medication, it will take away the hallucination, but it can increase the potential of your extrapyramidal syndrome. That's why it's called EPS, because now it's characterized of muscular movement that are involuntary. That's why it's proliferate. So there has to be a way that you balance this out. Okay, so that's what we're going to be talking and discussing later on as we relate the medication. Then we go into your tuberoinfundibular pathway. Your tuberoinfundibular pathway relates to the production and the release of prolactin. Well, we know that's why it's in the green pathway here, and it's somehow related to even the pituitary, because in the posterior pituitary, if you remember, that is where the production of your in the posterior pituitary, where the tuberoinfundibular pathway is also right there in that section. That's where the prolactin. Remember that prolactin is the hormone that's responsible for you to lactate, especially during pregnancy. It starts to build up, and during postpartum, prolactin is so high so that a woman can produce, milk. But it is not true to all. We're not all needing high elevation of prolactin, because men, of course, does not lactate or does not need to lactate and breastfeed, and even women are not all in productive years, or not all are, even if they're all productive years, they are not pregnant or they're not on postpartum, that they need a lot of this hormone to produce milk. So your tuberoinfundibular pathway is affected by that. With a normal amount of dopamine, it controls, okay? It inhibits, the dopamine inhibits the increase of production as well as the release of this hormone into the bloodstream. Being a hormone, is released into the bloodstream. So what would happen? Again, I'm going to go back just like your nigrostriatal pathway, that when you're trying to control your mesolimbic pathway by decreasing dopamine stimulation, you're also decreasing the dopamine in the pituitary gland. So what would happen? You use an antipsychotic, like for example, Risperdal, I would say, and we'll talk about Risperdal later on. It decreases dopamine availability and response to the receptor, so that hallucination go down, but the decrease of dopamine availability as well as receptors stimulation of dopamine in the tuberoinfundibular pathway would also decrease the presence of dopamine that controls the release, that inhibits an elevation and the release and production of your prolactin. So that's the reason why there is a risk that if you decrease the symptoms with dopaminergic properties in the mesolimbic, you're also risking now a surge of prolactin in the blood. So then you have to look at now the presence of EPS as it is affected by decrease of dopamine in the nigrostriatal pathway and the surge of prolactin as dopamine is decreased in the tuberoinfundibular pathway. So now you have these four pathways that you will have to balance out. You know, the mesolimbic pathway to control the positive symptom, the mesocortical pathway to also mediate and moderate the negative symptoms, and then you're looking at that symptomatology wise and its effect to two other pathways, the nigrostriatal, which is now the decrease of the dopamine as a result or an intended result coming from your medication might create a more surge of involuntary muscular movement, as well as in the tuberoinfundibular pathway that a decrease of dopamine may create the surge of the release of the hormone prolactin. So I hope you have a bigger picture here now. I'm going to go into each one of this individually. So let's talk about your mesolimbic dopamine pathway. As I've said, it is important in emotion and behavior. The mesolimbic dopamine pathway is the basis of the positive symptoms of psychosis, not just schizophrenia. Okay, by the way, not just schizophrenia, but also psychosis. Remember, one can be psychotic, but not necessarily schizophrenic. Okay, one can be psychotic, but not necessarily schizophrenic. Although schizophrenia would manifest all symptoms of psychosis, not all psychosis are schizophrenic. Why? Because you have drug-induced psychosis. It manifests positive symptoms of psychosis, hallucination, delusion, illusion, paranoia, but they are not schizophrenic. It's induced by drug. You also have what we have too much dopamine, again, that creates mania, might have create psychosis. So you have manic with psychotic feature. There are even people that has depression with psychotic feature, but not necessarily schizophrenic. Okay, but all schizophrenic are psychotic, but not all psychotic are schizophrenic. Okay, just wanted to let you know to remember that. So your mesolimbic dopamine pathway is the basis for the positive symptoms. What did I say again with the positive symptoms? What's supposed to be not there are added. They see things that are not there. They believe on things that is not necessarily related to what is reality. So they have delusion of grandeur, delusion of persecution, paranoid delusion, nihilistic delusion. So you remember all those type of delusion you've learned in your basic psychiatry. So this is the basic. The basis of the positive symptoms of psychosis here is then the patients, as I've said, they will experience delusion, hallucination. This usually would catch the attention, you know, of the family member, people around the patient, that they start saying, why is he talking? He's responding to auditory hallucination. You know, these usually catch your attention are the positive symptoms of psychosis. They're not focusing now on what's real. They have their own world, which is unrealistic. So example of manifestation of your positive symptoms, as I've said, are delusion, hallucination. So your mesolimbic dopamine pathway is also very important because it's responsible for motivation, pleasure, and reward. So you could just see that in this mesolimbic dopamine pathway, if a person has too much surge of dopamine or the receptor has been overstimulated with dopamine, then they are highly motivated. They lost control. They all want their id, their pleasure, you know, and they can do things out of norm. And this catch your attention. Okay. So I've mentioned before, your dopamine receptor is primarily your D2 receptor. Your D2 receptor is the primary receptor of this pathway. D2 receptor is the primary receptor of this pathway. So if we want to control the effect of dopamine in the D2 receptor, there are medication that blocks. There are medication that blocks D2 receptor so that they will not be able to be stimulated by the presence of your dopamine as your neurotransmitter, which is excitatory in nature. And then if you have too much of that, again, as I've said, that creates the symptoms of your positive symptoms of paranoia or of psychosis, and that certainly of schizophrenia. So, so again, the positive symptoms is a present of something that is not normally present. Example, hallucination, delusion, bizarre behavior, paranoid, and this gets our attention, and this is the primary symptoms that we can control using the drug therapy. So because this catch your attention, they're talking, they're responding to voices, we would like to limit this to decrease your psychotic symptom. So we do that by looking at and controlling the dopamine availability and dopamine stimulation to the receptor, especially D2 receptor, in the mesolimbic dopamine pathway. So as I've said, your D2 receptor is the primary receptor of this pathway, and diseases or drug that increase dopamine will increase the senses and symptoms in this pathway. So what are those drugs? What are those situation or condition or diagnosis that may increase dopamine in this? So like when a patient takes stimulants, you know, so stimulants, your ADHD medication, Adderall, Ritalin, you know, they're stimulants. They can also increase dopamine in this pathway, and thus it can potentially create hallucination in some people. That's why sometimes there was a time that I have a patient who has ADD, is taking Adderall, but at the same time he has psychosis and he has hallucination. He says, I like ADD medication, the Adderall, but the problem is that I will be so focused at work, but I also get distracted because I know the more focused I am, the more prominent is my hallucination. I hear voices talking to me, yelling at me. That's why I kind of don't like it. Although it improves my attention, it would make my hallucination more of a problem. And that was the immediate release Adderall and Ritalin that was given from previous provider. So what I did, I said, okay, let's play around with this. I know that stimulant stimulates dopamine to improve your attention, but for people who have psychosis, it can also improve the positive symptoms of psychosis, which is hallucination and delusion. And that's immediate release. So I said, well, we need to enhance your attention, still support your attention so that you could be a productive member of the society and you could continue your work. But we need to minimize the hallucinations. So instead of an immediate release, I will choose a drug that is controlled release. In that way, there is no surge of stimulant that stimulates dopamine receptor stimulation, but still maintain a controlled level of stimulant enough to maintain attention. So I went to Bivrid, which is a controlled release stimulant for ADD. The following month, he came back and says, you know what, Dr. Tan, I like it. I was still able to focus, but it does not make hallucination more prominent. I don't hear the voice, and I can maintain my attention. So I think I was able to balance out the therapeutic intent, at the same time decreases the overstimulation of dopamine in the mesolimbic to create the positive symptoms of psychosis, which is diminishing hallucination. It's the same with people who takes cocaine. You know, cocaine is a stimulant. It increases dopamine activity in the mesolimbic dopamine pathway. That's why people is not sleeping, they're stimulated, they're having fun, but at the same time, they may start hearing voices, seeing things, become paranoid, and symptoms of drug-induced psychosis is stimulated with presence of cocaine. So remember, again, stimulants work by increasing D2 or dopamine in this pathway. An example of this are your cocaine, meth, Adderall, Ritalin. Dopamine makes one excited and makes you feel satisfied and feeling rewarded and increased feels of sensation and euphoria. Dopamine is fun, but too much dopamine can lead to symptoms of psychosis. So talking about your antipsychotic medication to some extent, your antipsychotic medication as it relates to your understanding of your mesolimbic dopamine pathway is that your antipsychotic medication to some extent, they all block dopamine receptor. They all block the dopamine receptor in this pathway. So there will be less reaction of excitability brought about by dopamine in here. So that's why we control the symptoms. All antipsychotic, after all, I want you to understand that all antipsychotic seeks to control the psychotic symptoms and the psychosis per se. And this is the product of overactivity of this mesolimbic pathway. So because psychosis is the product of overactivity in the mesolimbic pathway, your antipsychotic seeks to control by blocking dopamine in this pathway. Any effective antipsychotic medication is aimed, okay, I want you to remember that any effective antipsychotic medication is aimed at blocking the receptors in this pathway. So it blocks, so what happens to the dopamine effect? Decreases, okay? But that's what we try to control. However, later on you will understand that the blocking of dopamine in this pathway, as it controls psychotic symptoms, it can create problems in other pathway. I want you to think through that because we will go through it. So all antipsychotic here are treated with positive symptoms of schizophrenia, block D2 receptor in this pathway. This results in mesolimbic dopamine hypothesis of schizophrenia. That's why there is what we call as the mesolimbic dopamine hypothesis of schizophrenia, because it is the presence and overstimulation and presence of too much dopamine or overstimulation of the receptor in this pathway that it creates the symptoms of psychosis, such as symptoms of schizophrenia. So I hope you understand where the dopamine mesolimbic dopamine hypothesis of schizophrenia, that its presence of symptoms, the positive symptoms, is created as a result of overstimulation, of course, too much dopamine or overstimulation of the pathway with dopamine, that it creates those symptoms. So in a nutshell, new and old medication, or old in the case, the Haldol, Prolexin, and even new medication, new antipsychotic medications such as your atypical antipsychotics, all block D2 receptors. They all block D2 receptors for dopamine to stimulate. So they all, in a nutshell, they all control the psychotic symptoms. The problem is also balancing the side effect, is where the clinician's responsibility sits. Why? Because this is just one of the pathway. Remember, if we block D2 receptor to the effect of dopamine, there are three other pathway. You have your mesocortical, you have your nigrostriatal, and you also have your tuberoinfundibular, right? They have different function when it comes to dopamine. So when you block the positive symptoms, in the mesolimbic dopamine, you could also block dopamine in your mesocortical. But remember, dopamine is needed in the mesocortical, and that's the next discussion we have. And make sure you also take into consideration that dopamine also is needed in your nigrostriatal to control your involuntary movement. And when there's less dopamine, you may have more of the involuntary movement as you use a medication to control your mesolimbic dopamine pathway. It's the same with your tuberoinfundibular pathway. You need a dopamine to inhibit release and production of your hormone, you know, so your lactating hormone. So a less or a blockage in the receptor D2 in that may surge prolactin, and then you have too much prolactin. Then we discuss it, and then I just want to make sure you have now the picture. Then let's go to mesocortical. We know that in in the mesolimbic theory, we control dopamine, D2 receptor stimulated by dopamine. That's why we try to control hallucination and the positive symptoms. So talking about mesocortical dopamine pathway, this is the pathway originating in the same place as the mesolimbic pathway, but projects to the prefrontal cortex. That's why you have that in the picture earlier in the red pathway, that it goes all throughout the cortex. This area regulates, remember that in your cortex, where the mesocortical pathway is also responsible in regulating cognition, executive function, affect, and emotion. So we think of cortical as we think of cognitive, okay? So cognitive function of the brain, understanding, learning, memory, are all in your cognition, learning abilities, understanding, insights are all in your cognition and are part of your cognition. So it will, in here is that the deficiency of dopamine leads to the problem in these four areas also, such as, again, as I've said, cognition, executive function. So when we say cognition, it's the ability to receive information, it's the ability to remember things, to learn things along the way. When we talk about executive function, we're talking about the ability to execute a thought. That's why it's called executive function. It's the ability to execute a thought process. So the ability to execute a thought process is somehow also related to your decision making. That's why your thought is this. That's why you could make a choice. You could make a decision. It's your ability to problem solve. It's ability to judge. Remember in your many mental eval, that you always would include that. That's the reason why you ask, do you remember 3 things that are not related? Because you're actually testing the executive function of memory, the cognition, and then you have executive function of, if this room gets in fire, what you are going to do. If you see $100 bill, what were you going to do? Those are questions about judgment, So, and then question about problem solving and decision making also is being included in your many mental eval, because that's an example of how you test your cognitive function. Normally, we need the dopamine to allow us to do these things. The problem here, or I'll go into the problem later on, affect. We remember that affect is the appearance on how they look, how they look based on how they feel. Well, that's normal. You feel happy, you smile, you laugh. You feel sad, you frown, you blunt, you don't usually get engaged. But remember that your affect, they are not always congruent to how you feel. That's such thing as what we call as inappropriate affect. When we say normally in the enough amount of dopamine that your affect is a reflection of how you feel. But for people whose dopamine level are low or there's not too much dopamine, their affect might not be congruent to how they feel. And that's a problem also with your psychosis because affect is not always congruent to how they feel. There is what we call as inappropriate affect. You know, they feel sad inside, but they're laughing outside. Or they feel happy inside and they're crying outside. Their affect does not match because of the imbalance of neurotransmitter. Or they could be blunted. They lack the expression of, you know, if a situation calls for them to be happy and elated, they will just probably look at you and blunt, very blunt, which is not related or not congruent to how they feel. So aside from the opposite, which is inappropriate affect, they can be blunted or flat, no change at all. Especially happening when there is an imbalance of neurotransmitter in this pathway, in the metacortical dopamine pathway, where normally with enough stimulation but not overly stimulated, cognition and learning is facilitated, executive function is practiced, affect is congruent, and emotion is related to the situation. Again, the problem here is that in many people with imbalances neurotransmitter in the pathway, it may produce an affect that is not congruent or not related or not enough to express what they feel inside as their mood and emotion. So that's the problem here. Because in schizophrenia, then I will go that in schizophrenia, there is lack of dopamine in this pathway. That's the reason why it supports the negative symptom of schizophrenia. Okay? So the negative symptoms of schizophrenia or the negative symptom of psychosis, when there is problem expressing out, they don't learn. Well, in fact, I gotta tell you, IQ, they're very low in IQ. Schizophrenic and psychotics have low IQ because of the lack of dopamine in this pathway. Well, IQ among the manic or the bipolar are high. That's why they're leaders. They are impulsive. They are very influential. They learn a lot. They probably have 2-3 degrees, PhDs, you know, because they're very good at cognition, but there's just too much in their manic phase. In this case, among schizophrenic, what happens is there is lack of dopamine in this pathway. So currently, the theory is that a deficit of dopamine in this pathway produces the dysfunction of the system. So it is the deficit. So consequently, a deficit of dopamine leads to the deficiency in these 4 areas also: cognition, executive function, affect, and emotion. So the mesolimbic, in the mesolimbic pathway is where D2 receptor is being blocked to control the positive psychosis. Then those medication, if they block dopamine in the mesolimbic, they can also block or decrease dopamine in the mesocortical pathway. That's the problem now, because we try to block dopamine in the D2 receptor in the mesolimbic so that the positive symptom decreases. It can also block dopamine in the mesocortical pathway, who's already having deficiency in to start with. That's why they manifest the negative symptoms of schizophrenia. So what would happen here? Then a real problem with cognition becomes more prominent, more problem with executive function, more inappropriate or blunted affect is more observable, and they're not able to express out. There's apathy of their emotion. So now you have the 2 areas where we try to control with antipsychotic that decrease the D2 receptors reaction to dopamine to decrease the positive symptom, which is what caught our attention. We would like to control those hallucination, those paranoia, those delusion, but then we pull down their cognition more. That's what happened when antipsychotic was created, and the first generation, your Haldol, your Prolexin, you know, your Thorazine is the first one that has been developed. They all, yes, we got it in science. They control the positive symptoms of psychosis. They control hallucination, illusion, delusion, paranoia. But we make them a robot. They're not reacting. They're so blunt. They're so they're so slow to move because it also decreases the dopaminergic activity or the dopamine even supply in the mesocortical dopamine that they function so bluntly. So again, controlling the symptoms doesn't mean always quality of life. Because now we control hallucination, delusion, and psychotic feature, but they are unable to work. They're also not able to think, they're not able to relate, they're not able to make decision making because we also decrease and block dopamine that is low already to start with in this pathway. I hope it makes you understand. So blocking D2 in the mesolimbic is good to control the positive symptoms, but in mesocortical is bad in a sense that other function of cognition becomes more prominent. Well, as I've said, that is the problem with the older antipsychotic medication. They don't hallucinate, but they have problems with their ability to think. They are blunted affect. Even their ability to feel emotion is taken away. This makes this drug so difficult to balance. You solve one problem, you overexpand in the other problem, the negative symptoms. Then let's talk about the nigrostriatal dopamine pathway. Okay? This pathway is not directly implicit in the psychotic symptoms. As I've said before in the introduction, this pathway is not directly related to the psychotic symptoms. This is the pathway that is integral to motor function and movement, however. So if they are not directly implicit to the psychotic symptoms, its relevance is that it is the unintended consequence of dopamine blockage brought about by our pharmacologic agent that becomes our concern. Because this pathway is part of the extrapyramidal nervous system. As I've said, in nigrostriatal dopamine pathway, the presence of dopamine actually in the extrapyramidal nervous system is inhibitory of the function of the extrapyramidal, which is responsible for the involuntary movement. So the presence of dopamine here inhibits extrapyramidal nervous system. That's why we don't have involuntary movement. We could control our muscle purposefully so that it enhances the pyramidal nervous system, which is responsible of our voluntary movements. Well, later on you would know, or perhaps take from the effect of controlling the mesolimbic is a disaster. Controlling the mesolimbic stimulation of dopamine becomes a problem in the mesocortical because it inhibits cognitive function. Again, I'll brought you to the attention that the extrapyramidal section is responsible for the involuntary movement, while that of the pyramidal system is responsible in the voluntary movement. So think about, how could I give you an example to this? And I think I have already from before. In Parkinson's disease, where it is a disorder of the motor due to decrease in dopamine in the nigrostriatal dopamine pathway, remember what we do here? We give them dopamine, carbidopa, levodopa, which is dopamine, to control this shuffling, mask face, rolling, pin rolling, and then shuffling movement. We give carbidopa, levodopa to enhance the dopamine because that controls your extrapyramidal nervous system so that shuffling, tremors are decreased. So that's what we do here. We need dopamine in this pathway to maintain normal motor function, to keep our purposeful and voluntary movement. Now, where are we having some problem here? Is that any abnormalities of the extrapyramidal system is linked to the involuntary motor movement. So now, in the extrapyramidal system, if we decrease the dopamine, it increases the involuntary motor movement. Deficiencies of dopamine in these pathways can therefore lead to movement and abnormalities seen in Parkinson's, and that's what I described before. So let's look at, for example, now your medication. Oh, let's go back to the whole thoughts back again. I know it's going to go back and forth. I want you to be very familiar with this function. So we use antipsychotic. Probably, just to make it extreme, we use first generation antipsychotic, which also is true to the other atypical later on. We know the science that when we use this type of antipsychotic, it decreases dopamine receptors reaction in the D2 receptor in reaction to the presence of chemical called dopamine. Okay? So it decreases. So that it decreases, we know that it certainly decreases uncontrolled symptoms of psychosis. But its effect is what we don't want in the nigrostriatal. So therefore, we tend also to block dopamine receptor to the action of dopamine, which fortunately controls the involuntary. So what would happen? We decrease dopamine here unintentionally as we decrease dopamine receptor or black dopamine receptor in the mesolimbic. What would happen? It can flare your extrapyramidal nervous system's control of involuntary movement. So the decrease of dopamine in this system creates more prominent extrapyramidal involuntary movement. That's why we call it EPS, extrapyramidal syndrome, brought about by use of antipsychotic that decreases dopamine in this neural pathway, leading to side effect. So that's the reason why we said it is not implicit to symptoms. However, it is important because the use of medication that decreases dopamine in this pathway will create more prominent side effect, not necessarily the symptom. That's the reason why you have to watch your patient who is on antipsychotic and they start manifesting EPS or extrapyramidal syndrome. That is the adverse reaction of your medication because it decreases dopamine activity in this nigrostriatal dopamine pathway. So deficiencies of dopamine in the pathway may lead to Parkinsonisms. We talk about that. I discuss about that symptoms of Parkinsonism. I will have another table following this to differentiate. Akathisia, dystonia, and tardive dyskinesia. I put an asterisk in the tardive dyskinesia because these symptoms are reversible when you discontinue the medication, but tardive dyskinesia with an asterisk here because this is the one that is not reversible. So when we say reversible, that means, when we stop the medication that blocks dopamine in the nigrostriatal pathway, involuntary movement also would decrease because now there's enough dopamine to prevent the pyramidal nervous system in acting out. That's why your involuntary movement is more controlled. However, tardive dyskinesia brought about by this medication may stay longer and it may not be reversible. Okay, may not be reversible. So I don't know how many of you still watch TVs, but if you watch TVs, especially late night, past midnight, and you still watch TVs, you could see more advertisements saying, if you're taking this medication and your doctor has not, and you experience the symptoms, involuntary movement, twitching, muscle twitching, you may experience some um, unintended adverse reaction to the medication you're taking. If you're taking antipsychotic, see me, and then there's more money involved, let's have a litigation, something like that. And this is where it comes from. You've got to remember that there are those, especially tardive dyskinesia, that is uh, not reversible, and that's maybe the cause why they're suing you. As a provider, you got to make sure you also watch this. So extrapyramidal syndrome, I think you understand now. Extrapyramidal symptoms is brought about again by the decrease of dopaminergic activity, which is inhibitory of the extrapyramidal nervous system. Therefore, it controls involuntary movement. As the decrease of D2 receptor stimulation of dopamine, then extrapyramidal nervous system would flare up, and then there's more prominent involuntary movement, collectively called EPS, which is a very big, or extrapyramidal symptoms, which is a big adverse reaction of your older antipsychotic, the first generation antipsychotic, which is they are very prominent with EPS. So EPS is a collection of involuntary muscular movement due to decrease in dopamine activity in the nigrostriatal dopamine pathway. So what are they? They involve Parkinsonism, which usually occurs within 1 to 4 weeks after initiation of your treatment. It is characterized by rigidity, shuffling, gait, pill rolling, hand movements, tremor, and a mask-like face. Then you have akathisia. Akathisia occurs within 1 to 6 weeks after initiation of your antipsychotic medication, which is characterized by recklessness, agitation, and pacing. So you have a person here who manifests Parkinsonism, pin rolling, rigidity, shuffling gait, and tremors and mask-like face, but they also move restless. They pace back and forth. That is akathisia. That would happen 1 to 6 weeks after initiation. And then it goes with dystonia. Dystonia, which occurs 1 to 2 days after initiation, is kind of really fast. Your patient is not only rigid, shuffling, having Parkinsonism, restless, agitation, pacing, going back and forth, one point to the other. They can also have limb and neck spasm. They can also have leg and neck spasm, uncoordinated jerking movement, and difficulty speaking and swallowing. There's also rigidity and muscle spasm that is noticeable. Let me go back my old. Okay, so you could see that's muscle spasm in here. Neck movement. So that is actually your dystonia. And then your TD, which I said can be irreversible or not reversible, it develops late in the treatment. So later on, it develops. Thanks God, because if you could see these three, Parkinsonism, akathisia, and dystonia, which happens, within 1 to 4 weeks, 1 to 6 weeks, 1 to 2 days. In fact, with dystonia, you have all the reason now to decrease or stop and change your medication before tardive dyskinesia develops, which is rather not reversible. Okay, so at least we prevent muscular problem. So when we say tardive dyskinesia, this is when they have involuntary tongue and lip movement, and also limbs and trunk movement. So twitching, you have their tongue twists out, they drawl, and they have like chewing problem, they smack in their face. That's the lip problem here. They develop tardive dyskinesia already. So what it is again? Parkinsonism, shuffling, rolling, akathisia, pacing, agitation, dystonia, twitching of the neck and the torso, uncoordinated jerking movement, tardive dyskinesia, tongue rolling, drawling, lip smacking, and so all those may happen. And collectively, they're called extrapyramidal syndrome. So I think I have a bigger picture in there that would show your tardive dyskinesia and involuntary muscle movement. I like you also to probably, however, click on this link or retype this link to see more sample in YouTube. TD is usually irreversible, and best treatment is to prevent. So prevention of this, the easier way is to decrease your medication or stop and change the medication as soon as you notice these EPS symptoms, because they can be prevent productive life, and maybe a cause of why people would sue you, not monitoring it. You got to be very careful with that. And if they do, and you weigh the risk and benefit, and you could document enough that there's more benefit staying in the medication, then you could probably balance out this by giving cogentin or benzotropine. Cogentin that decreases all this involuntary movement. Or as simple as I have some patient also that may have some side effects of your cogentin, then I could recommend also over-the-counter Benadryl. Your antihistamine, Benadryl, or your Vistaril can minimize. Also, benzodiazepine can also minimize this jerking movement, but the problem is it can be habit-forming in a long term, which is your Klonopin. It's a type of benzodiazepine. So now we go into your tuberoinfundibular dopamine pathway. So we already talked about mesolimbic, mesocortical, nigrostriatal. This time we'll talk about the tuberoinfundibular dopamine pathway. This is another pathway that is not directly implicit in the symptom management or the symptoms wise. We have that mesolimbic and mesocortical for the positive and the negative symptoms of schizophrenia. Tuberoinfundibular, like your nigrostriatal, is not directly to the symptoms, but rather the side effect as we incorporate pharmacologic agent. So this becomes important because the unintended consequence of blocking dopamine pathway, blocking in the case of using pharmacologic agent that blocks the pathways, results in the interruption of the normal mechanism to inhibit prolactin release. So I would like you to think that in this pathway, the tuberoinfundibular dopamine pathway, dopamine inhibits prolactin release. So what would happen, of course? So your tuberoinfundibular normally maintains the prolactin level released from the post-pituitary gland. That's why if you remember that brain sketch that I showed you, the green pathway, which is the tuberoinfundibular pathway, is somehow within your pituitary gland, because it's the post-pituitary gland that it's the primary that releases prolactin. That is the primary hormone that stimulates milk production. Normally, we don't want lots of prolactin release because not all of us are nursing. Not all of us are in postpartum. I lost the term. Postpartum time. So dopamine is an inhibitory neurotransmitter in the CNS and is important in this pathway because it inhibits prolactin release. So it inhibits prolactin release. If we block dopamine activity as in the control of positive symptoms of psychosis in the mesolimbic, we can also block the dopamine action to inhibit the, the prolactin release. And as a result, prolactin level increase, and some will have developed galactorrhea. Not only will it increase in level, its increase will produce even discharges in the nipple. Galactorrhea, and in men, in men, it may even stimulate your gynecomastia and then lead to galactorrhea. It is very, very disturbing in body image in men, and especially when you're treating young people, young boys, with antipsychotic, and then they develop gynecomastia and galactorrhea. That's very that's very concerning, and it probably be very, very disturbing to them. And as a result, there are even parents, again, you will see that in TV, enticing them that if they have this, you'll be poorly monitored, then we will start a lawsuit. We don't want that to happen. The whole thought is that if you inhibit the inhibitor, so therefore you inhibit the dopamine, which is an inhibitor to the release of your prolactin. If you inhibit the inhibitor, one may start producing prolactin more. So there will be a condition called hyperprolactinemia, which is one of the problem and side effect of many antipsychotic. So an unintended consequence of blocking your dopamine pathway results in the interruption of normal mechanism that inhibits prolactin release. Thus, it would surge and increase in your bloodstream. So under normal circumstances, I've said dopamine activity in this pathway inhibits prolactin release from the posterior pituitary, and dopamine block interrupts its inhibitory effect. Subsequently, there will be an elevated prolactin level. So that's the unintended problem here. And along with it also, in the tuberoinfundibular dopamine pathway, other consequences of hyperprolactinemia also may occur. So you need to also monitor. And this can happen in both gender. So there will be gynecomastia, galactorrhea, gynecomastia, enlargement of the breast tissue, galactorrhea, not so much prominent in women because they already have some breasts, but more prominent and more observable in men. Galactorrhea, and then amenorrhea, especially in productive years, and some sexual dysfunction. So it has its secondary consequences also. I remember I have a patient, a female, who's very manifesting psychosis, and I put I put her on risperidone, which is atypical antipsychotic, but after 1 month she was complaining of watery discharge in the breasts. So I don't know if you know the normal levels. I want you to know, I may probably discuss that later on. So around 20 nanogram for non-pregnant women. That's a normal level of your prolactin. But when I run her prolactin, it was even just a month of using it, it went to 46, and she started lactating. So I have to taper it down and stop it. When I stop it, the following month, we have another follow-up, and it dropped down to 18. It normalizes it. So it's very, very prominent. You need to make sure you monitor, and you don't only monitor, you discuss this so that they can watch. The good, I discussed this with a patient. She was able to watch, and she was able to prompt me out, and I was able to intervene. Okay. So let's look at this. This is how we integrate dopamine hypothesis in schizophrenia. So we have the mesolimbic pathway here. An increase, or this represents the dopamine level across. It has different picture in the different pathways. The mesolimbic theory, the mesolimbic pathway among schizophrenia, there is an elevation of dopamine activity, meaning Dopamine activity might be presence of too much dopamine or increased sensitivity of the receptor, especially D2 receptor to dopamine. So there is high dopamine activity which creates the symptoms or positive symptoms of schizophrenia. While in schizophrenia, in the mesocortical pathway, okay, in the mesocortical pathway, there might be two pathways here. So that's why there's two. The dopamine activities are low. A low dopamine activity present in schizophrenia leads them to have cognitive problem, affective symptoms, black, flat, inappropriate. So negative symptoms is prominent. Positive symptoms, hallucination, delusion, all what's added on, while negative symptoms, someone is taking away. They have problems understanding, they have problems with memory, expressing, their affect is blunt or flat. That's when you have low. Normally, then they have schizophrenia long, affected by dopamine balance and level in these two pathways. There's two, it's all two mesocortical because there's two sub-pathway here. Anyway, but the nigrostriatal pathway and the tuberoinfundibular may have normal dopamine, but they don't affect symptoms of schizophrenia. They only is affected with the side effect of the medication we use, which we want to understand so that we could consider in making decision. So that's how the hypothesis of schizophrenia happens with your pathways and how your dopamine can support or create that problem. Then we look at, Then we look at using your first generation antipsychotic, also known as your conventional or typical antipsychotic. Remember because we want to solve this problem, we try to use pharmacologic agent. So remember, using your conventional or your atypical antipsychotic, this is the oldest group of drugs to manage psychosis, and they are very effective in managing the psychosis. So again, the effectiveness is there, but the side effects are concerned. But the effectiveness, when it comes to intended outcome, is very good, but does it improve quality of life or does it create another problem? So these are classic D2 antagonists. So these are, or dopamine antagonists. These are classic dopamine antagonists are your typical medication. They're very effective psychotic symptoms, especially positive symptoms. Our problem here is the side effect. So let's look at how it now fits into our previous gap of what happens in the dopaminergic hypothesis here. So now we use antipsychotic, and it so happen we'll try to use the first generation antipsychotic, which is D2 blockage or antagonists. They block the effect of dopamine in the D2 receptor. So normally, again, in the mesolimbic theory, the dopamine is high. It has positive symptoms of schizophrenia. We block the dopamine activity, symptoms improve. Hallucination goes, delusion goes away, paranoia is controlled. They're no longer suspicious. They're not hearing voices. They're not thinking they're the king. They don't have delusions anymore. Symptoms positive improve. And then in the mesocortical pathways, where originally they're slow, the problem is when we use the pharmacologic agent, which is D2 receptor, to start where they're already low, what happens? It makes the symptoms in the mesocortical pathway worse. They don't have hallucination, they don't have delusion, but they still have very blunt in affect. They cannot understand. They have problems in memory, in learning, and cognition. All the negative symptoms get worse. So now you could see now the effect. This becomes now more prominent negative symptoms as a result of blocking the dopamine activity. It improves the positive symptoms, it makes it worse here. Then we look at what originally is normal level of dopamine in the nigrostriatal pathway, but with the effect of the blocking the mesolimbic pathway, it produces now EPS. So what normally the level of dopamine that normally inhibits the extrapyramidal nervous system, there is no control, there is more involuntary movement noticing. So EPS becomes more prominent. The same time in tuberoinfundibular pathways, where there is normally enough dopamine to control the release and the surge of prolactin. With the effect of blocking it, it can also block dopaminergic activity in the tuberoinfundibular pathway, increasing prolactin release. Then galactorrhea happens, or increase in prolactin level would increase. So this would summarize now the effect of what we just have discussed. Okay, so in our next discussion here, I will be talking about different medications, starting with first generation antipsychotic. But this is what I'm going to do. I'm going to stop this recording in here as the first part, or part one of your antipsychotic, which I finish up discussing to you about the the theory of schizophrenia, or your hypothesis theory about schizophrenia, and focusing on the three neural pathway: your mesolimbic, your mesocortical, your nigrostriatal, and your tuberoinfundibular, and how it relates with medication use. So I will stop here as the first part, and then you will have a second video. This time we'll be focusing on how this neural pathway is impacted with the use now of specific medication, or specific antipsychotic medication. And this is now part of the objective, where we'll be talking about comparing and contrasting your first generation and second generation. That will be in part 2, and that's where I'll pick up into the second part of this video. So right now I'm going to stop as part 1. You will have another video proceeding with your antipsychotics, starting with the first generation antipsychotics, and that will be the start of our discussion as we start part 2 of this video content discussion.